to those of you joining us from different time zones across the world. I am delighted to welcome you to the third in the seminar series organised on behalf of the Lancet Commission on Gender and Global Health. My name is Sarah Hawkes. I'm based in the UK at University College London, and I'm absolutely delighted to welcome two commissioners to talk to us today. We are going to start with Professor Cathy Campbell, who was Professor of Social Psychology at the London School of Economics and has focused her career on understanding and looking at social movements for health. And then Cathy is joined in collaboration with Renu Khanna, who is based at the Society for Health Alternatives in Baroda, India, and is a leader in the field of social movements for health improvement for women. So we're bringing together both the theoretical and the practical and the experiential all in one talk today. So for those of you that are joining this seminar on YouTube, first of all, a very big welcome to you all. But secondly, if you have got questions, please type the questions into the YouTube chat, because it's the only way that we can actually see the questions for the speakers. So if you could just put the questions in as the talk goes along, they will come across to us, and I'll be able to pass those across to Renu and Cathy at the end of their talks. So Cathy, over to you to start us off. Thank you very much.
Thank you, Sarah. Thanks to the Commission chairs, Sarah and Pascal and Assi, for hosting this event. Thanks to our fellow commissioners, who's such an inspired and inspiring group. And thanks to Emma and Anna, who've put a huge amount of effort into organizing this webinar. This is going to be a sandwich presentation. I'll talk at the beginning and the end, and Renu will talk in the middle. Our paper is framed by our interest in the role of public health in tackling health inequalities. Our primary interest is in gender, and our starting point is an intersectional one, namely that the impacts of gender on health can't be considered out of the context of its intersection with other dimensions of social inequalities, including ethnicity, socioeconomic status, social class, caste, and so on. Next, please. The aim of critical public health is to empower marginalized people to take control over their health. We have a particular interest in the role of community mobilization in advancing this goal, and it takes many forms in global public health. Instrumental approaches enlist communities to help delivering biomedical health services. Dialogical approaches promote interactions between professionals and communities to create services that resonate with users' lay understandings of health and healing. Social capital approaches increase the participation of marginalized people in local community groups, such as women's groups and faith groups, given research that belonging to certain groups may have beneficial effects on health. And finally, critical approaches embed all these efforts within a wider political emphasis, viewing community mobilization as a route to collective action to resist and transform the social inequalities that place people's health at risk. Next, please. The latter critical approach, which guides this paper, is rooted in the belief that efforts to reduce inequality should firstly promote the capacity of the powerless to demand their rights to health, and secondly, facilitate the development of social environments where the powerful are likely to heed these demands. Historically, much public health has consisted of information, awareness, peer education, programs that seek to persuade individuals or small groups to challenge unhealthy behaviors. However, experience has repeatedly shown that social circumstances often stand in the way of health-enabling behaviors in ways that lay beyond the reach of local community influence. And it's long been argued that programs need to go beyond simply seeking to persuade individuals to change unhealthy norms and behaviors. They also need to work to create social contexts that enable and support the possibility of behavior change. Next, please. Community mobilization approaches are frequently regarded as state-of-the-art strategies for creating such health-enabling environments. They often draw on the classic work of Freire in mapping out the pathways between mobilization and health. Freireans characterize health-competent communities as contexts where community members share knowledge about health risks and engage in dialogue and critical thinking about the social drivers of poor health. However, in practice, most public health practitioners focus on facilitating the involvement of communities in local level changes. Fewer take account of the more radical dimensions of Freire's agenda, namely that the solidarity and confidence that results from effective community mobilization should serve as a launch pad for collective action by the excluded to challenge wider inequalities that can't be tackled at the local community level. Health inequalities are rooted in power hierarchies that lie beyond the reach of local community programs. This has led for calls for community health practitioners to develop more explicit and systematic strategies to tackle structural barriers to health-related empowerment. There are growing calls for local initiatives to be used as starting points for more ambitious multi-level plans and partnerships, and for forms of social activism that explicitly highlight and challenge the wider power inequalities that drive ill health. Next, please. This is a difficult task in conditions of deep inequality. Powerful groups seldom redistribute health-enabling power and resources without assertive demands from the excluded. Yet such groups often lack the confidence and resources to make such demands. There is a lot to be learned from campaigns that have mobilized an effective push from below. These go beyond mobilizing marginalized people to understand and challenge the impacts of social relations on their well-being. They also pressurize power holders to heed these calls. In this paper, we showcase these points with reference to an initiative that has mobilized small groups of highly marginalized people into more ambitiously networked social movements. We do this to provide a productive lens for expanding the scope of an action and analysis in the field of community mobilization in public health. Next, please. The challenge of activism to tackle social inequalities is a great one in current times which are often hostile to human rights and social justice claims and to progressive social activism. Successes are often small and challenges are large. However, as we will argue, transformative social change is seldom a linear process. What are the possibilities and challenges facing activists who seek to challenge health-damaging social inequalities in difficult social times? And here I hand over to Renu.
Thank you, Cathy. And a warm welcome to all the friends who've joined today. Next slide, please. And the next one. So about Sahaj, we're a 36-year-old community-based nonprofit organization based in Gujarat, which is so-called a developed state. We have good economic and infrastructure indicators, but the social sector indicators are not commensurate with the economic development. Our work at the beginning in 1984 was with urban poor around their civil and political rights. And now in an experiment to implement an intersectional perspective, we also work with partners in tribal and Dalit communities, with young people living with disabilities, and with MSM and trans young people. Our work is framed within a rights and gender perspective, including the right to education, to health and healthcare, the right to food, sexual reproductive rights, adolescent rights, and right to shelter in an urban context where evictions and demolitions are routine. We are active in a number of pro-people networks and coalitions, the health movement, the SRH movement, through a coalition named Common Health, the newly formed Feminist Policy Collective, COPASA, Community of Practitioners in Accountability and Social Action in Health. Next, please. What are the contextual factors that we seek to address? Most prominent are the negative impacts of poor access and quality health services on the well-being of the poor and rural girls and women. They often have limited access to information and services relating to contraception, pregnancy care, safe abortion, laws that can protect them from domestic violence, comprehensive sexuality education, which is so urgent for young people. Some are at high risk of harmful traditional practices, including forced marriage, resulting in early childbearing, son preference, being branded as witches in the tribal areas where we work with our partners. The vulnerable groups, migrants, Dalits, disabled women and girls, and LGBTQI persons suffer in multiple ways. Poorly designed and implemented policies and programs end up increasing women's vulnerabilities. One example that comes to mind is the free cooking gas connection scheme. Women often don't have access to money to replace the empty gas cylinders, even though they have a free gas connection. Or the subsidized toilet scheme that results in increasing women's workload in areas where water sources are at a distance. Or the COVID response that did not factor in need for ongoing services related to women's reproductive health needs. Many progressive laws are enacted, but without the requisite implementation structures or human resources. Next, please. The health system in India has faced chronic challenges. Health budgets are insufficient to provide quality healthcare universally, even in economically well-developed states. For years, we continue at not more than 1.3% of the GDP spent on health, despite the National Health Policy 2017 promising 2.5% by 2025. There's a chronic shortage of skilled human resources in public facilities. The private sector is unregulated and exploitative. For example, in the COVID crisis, there are reports of rampant profiteering by corporate hospitals, especially in metropolitan cities. One shocking example is of a private hospital in Mumbai charging rupees 450,000 for 1 day's inpatient admission, which is more than 6,100 US dollars. The government's answer to many of these challenges takes the form of health insurance. And as argued by researcher friends, gender-blind health insurance not only leaves many pre-existing gender barriers unaddressed, but also accentuates others. Next one, please. Our strategies. We believe that our starting point should be constructive engagement with public systems, even as we enable communities to raise their own issues. Amongst communities, we disseminate information on laws, programs, schemes designed for women or children or adolescents. We focus on rights education amongst disenfranchised communities who find it difficult to believe that they have any rights at all. We network with coalition partners and we try to influence public discourse towards gender transformative policies and programs. Or if push comes to shove, we become part of pressure groups. Next slide, please. Our work on localizing SDGs. We are the national partner of Equal Measures 2030, which is a global multi-stakeholder partnership working on production and use of data for gender equality in the context of SDGs. The EM 2030 SDG Gender Index measures the state of gender equality aligned to 14 of the 17 SDGs in 129 countries across 51 issues, ranging from health, gender-based violence, climate change, decent work, among others. In India, we have been engaged with adapting the SDG Gender Index for advocacy. For example, we created a series of fact sheets based on a report by EM 2030 called Bending the Curve. We analyzed how long it would take to reach the SDGs targets at the current rate of progress on issues like access to contraceptive, women's perceptions of safety, laws for workplace equality, and so on. And just as an example, the policy brief on laws on workplace equality discuss the meaning of such laws in a context where 97% of women in India are in the unorganized sector. Next slide, please. So what is our perspective on localizing SDGs? We do this through enabling communities to monitor implementation of programs and schemes, by facilitating local organizations' participation in district and state level spaces, by helping local organizations and marginalized groups to generate evidence. Our data for advocacy workshops train local CBOs to understand indicators, locate sources of data, use this data to make their point effectively in dialogues with the health systems. CBO partners are supported to undertake small field studies to generate primary data on existing state of services in their local areas. And we specially support invisible groups to generate data to fill in the data gap in the larger, bigger data systems. Next slide, please. These photographs try and give a flavor of how we attempt to localize SDGs. The first photograph shows a women's collective meeting in a village where they articulated their issues, and we told them about the government's commitments to SDGs and the programs that the government has designed related to each of their issues. The second photo is orienting women attending the Village Health and Nutrition Day about the 9 services that they're entitled to receive. As a result of the orientation, they can then monitor these services. Next slide, please. This slide shows the kinds of state and national level reports that Sahaj and its partners has been producing. These reports are produced through a collective participatory analysis of government's published data using a gender and equity lens, complemented with local people's stories and narratives based on their experiences with the health system. These are thus civil society SDGs shadow reports for the states where we work. The important thing to note here is that these reports are translated into the local language so that there is ownership by the local CBO partners, who then use the reports for state level advocacy along with broader multi-stakeholder alliances. Similarly, for national level advocacy. For example, these reports were released collaboratively with the wider Feminist Alliance and UN Women in 2018. Later, the Feminist Alliance formally named itself the Feminist Policy Collective and has since engaged in a gender critique of national budgets, policies, and programs, including the government's COVID response. Next slide, please. So we have had some very modest successes. Awareness of the global SDGs framework, of India's SDG indicators, of Niti Aayog, our national planning think tank, and the SDG India Index and Health Index that Niti Aayog is producing has increased. Local groups can now use the SDGs framework and the language while training their demands. There is increased agency of the MSM and trans groups in particular and other marginalized groups in other contexts. The Sahaj Data for Advocacy workshops became an inclusive space with the presence of the MSM and trans groups, and they educated other participants on their issues. Solidarity increased. We could see this in the large turnout for the city level Pride March in 2019. Response of the state level SDG cells has been variable. In 2 states, good. They view CSOs as a technical resource and their eyes and ears on the ground. In 1 state, they ignored us totally. In yet another, the cell was only just starting, and then the COVID put a spanner in the works. And we are now renewing our relationship through the state UNDP office. Next slide, please. This is another set of photographs of how community report cards are shared with the community to secure buy-in and then used for district level dialogues. You can see 2 community level meetings here. one with the Women's Collective and the second with some village leaders. And finally, the entire group with the district health officer and his team, where the women share the results of their monitoring and then say what they want from the district health team and what they are willing to contribute to solve the problems that they are positing. These sort of meetings and dialogues then become regular and contribute to trust building. Next slide, please. So there are plenty of challenges that we face, and we have categorized them into two. This slide shows the challenges at the very practical level. People find it difficult to relate to the distant global SDG framework. The government tends to push existing schemes and programs into the SDG framework as a means to reach the targets rather than doing something fundamentally different and transformative. Monitoring is not institutionalized yet at the local level. And of course, there is serious resistance to community monitoring. There's a lack of continuity due to nodal persons getting transferred frequently. Next slide, please. But there are these larger challenges that we hope this commission will engage with. There are increasing risks in the current context, especially for the most disenfranchised who cannot afford the costs of speaking out. Survival and daily wages are critical for them. There is no way they can afford costs of legal action if they're detained and arrested. Another issue relates to the dominant paradigms of what counts as evidence. Testimonies and narratives are not considered evidence. In this project of global to local and local to global, how do organizations such as Sahaj position themselves in relation to the marginalized? We become power holders. There are issues around representation of marginalized voices. What long-term strategies should we therefore forge so that the left behind can ultimately represent their own issues at the national and global levels? How long should we give ourselves to play the role of brokers or mediators? What can be some indicators of success of increasing autonomy of grassroots movements? How can resources for organizing and capacity building of grassroots coalitions be mobilized? We see and experience fragmentation of social movements based on identity politics. How can we address these challenges? Next slide, please. And so what's the way forward? We believe that we have to continue to build solidarity, but how in these contexts of polarization? We need to support the consolidation as well as expansion of struggles and campaigns on the ground, and at the same time create the necessary vertical linkages. While doing this, we need to guard against the instrumental use of grassroots movements. And this underlines the importance of reflexivity. And it raises the question of the meaning of accountability. How can we be accountable to the grassroots movements, even as we participate with them in the challenging project of demanding accountability in a context of frequent systemic failures, corruption, and transnational corporate power structures? So I hope that we will be able to collectively think out of the box to address some of these compelling questions. Thank you for your patience, and over to you, Cathy. Next slide for Cathy, please. Emma.
Thank you, Renu. A few comments in conclusion. The starting point of our paper is that the mobilization of marginalized communities has a key role to play in challenging inequalities that undermine opportunities for health. But the efforts of marginalized people are only one layer of a wider multi-layered series of actors and agencies that need to press for change. We've presented a case study of an organization that has worked consistently to amplify community voices through leveraging links with appropriate partners. We've mapped out the role of Sahaj as mediator and bridge, bringing together disadvantaged people on the ground, global actors and funders, progressive activist movements, and sympathetic actors and agencies in state and national health services, in the media, and so on. Such alliances are essential for developing an effective push from below, one where the poor are able to make forceful demands and the rich are willing to listen to them. Sahaj's triumphs and disappointments provide valuable lessons about the challenges of achieving significant and sustainable reductions in health inequalities in highly unequal settings. Sometimes small gains can be achieved at the local level as a result of community-level activisms. Here and there, empowering mechanisms are created through dialogue with health service providers and district program managers. However, services are limited not only by the lack of such dialogue, but also by issues such as lack of government investment in health and social services for the most excluded, and staff shortages in health settings, and so on and so forth. These are corrections that need to be made at the state and national levels, sometimes with help from global agencies. We've already spoken of the difficulties facing progressive struggles across the world in the current social ethos. Social movements of women and public health activists, historically key allies of grassroots communities, are currently hampered by fragmentation. They often have to compete with each other for dwindling sources of funding for programs of social change. And they're often divided by intersectional differences and the resulting identity politics that fragment gender into different ethnicities, social classes, and so on. Next slide, please. Optimistic social commentators have long called for a politics of hope rather than despair, particularly at historical moments and in social environments that are not welcoming of emancipatory and critical social initiatives. They argue that so long as there are individuals or small groups who recognize the need to tackle social injustices, the possibility of social change remains alive. They see the waxing and waning of united progressive movements over time as held together by fine threads of continuous, quiet, and invisible work by small handfuls of committed individuals in the quieter years or decades. The tireless work of Sahaj and similar organizations in small marginalized settings around the world constitutes such quiet and often invisible work. Furthermore, critical scholars and activists increasingly reject the somewhat simplistic notion of social change that would suggest that it was a linear process, where the efforts of public health practitioners and activists are seen as inputs, with identifiable causal links to specific outputs. They argue that social inequalities, both global and local, consolidate in ever more complex and novel ways. And these contradict the old-fashioned notion of the excluded and their allies seizing control and resources from dominant power holders in identifiable grand gestures. They argue that activism in one time and place may not yield observable or immediate results, but may influence gains at future dates or in other places. At most, they argue that critical activists should find small cracks in the power of dominant groups and seek to widen these as much as they can, rather than expecting to achieve the large-scale redistribution of wealth or power through the grand gestures of single movements. The work of Sahaj, chiseling away at small cracks in the power inequalities that hold back marginalized groups over a 36-year history, constitutes such an approach. We are aware that such observations sit uneasily in a global public health community that is deeply committed to so-called evidence-based projects and interventions, dominated by methods such as randomized control trials that often individualize health. And in the types of evidence so loved by public health researchers and practitioners, social context is often regarded as a nuisance variable, or else operationalized in terms of discrete statistical variables that mask over the complex impacts of social context on opportunities for health. In the process, the field of global public health, with its quest for simple answers and generalizable bottom-line observations, often contributes to masking the complexity of social inequalities in health. And as such, it sometimes unwittingly serves as an ally rather than an opponent of social injustices. There's a desperately urgent need for a widening of perspective in the field, which will not happen in the absence of political will by researchers, practitioners, and funders. Next slide, please. We hope the Lancet Commission, of which we are part, will contribute to generating such political will through asking difficult questions and through posing problems whose solutions are by no means clear. In so doing, it will open up the possibility of generating new perspectives that open the field to new and innovative ways of being, seeing, and doing. Thank you.
Cathy and Renu, thank you so much. That was it was the most fantastic exploration of. I think it's probably too simplistic to talk about the link between theory and practice, but that beautiful way that you were able to illustrate how practical on-the-ground activities can be informed by theory, and conversely how theory is obviously informed by the experience of practice. That was a remarkable presentation. Thank you very much to both of you. We have a number of questions that have come in, so I'm just going to try and summarize a couple of them. And this is one that actually I'd written down myself but somebody else has asked it as well, which is when working with communities as true partners, what challenges have you, Renu, faced in addressing community power dynamics? And I guess seeing you on the theory side, Cathy, although I realise that there is an inherent crossover between the skills and experience of both of you, what does the wider literature tell us about overcoming opposition to community action? But Renu, perhaps I could start with you.
So the challenges are plenty, and the challenges, especially because we're working with women with a feminist perspective, get multiplied, because not only do we have to deal with the power challenges which are a result of caste or class structures within the village, but also of patriarchal structures. And so there has to be a multi-pronged approach, obviously. And as Cathy mentioned, and what has been the basis of our work has been the consciousness raising of women, collectivizing women, organizing them. And this is long and very painful work. And sometimes, there's also despondency setting in. But the incremental changes when women's collectives get empowered and can take on the patriarchal structures and the power structures in the villages, that's when, we see the fruits of our work on the ground. So I don't know whether I've managed to answer the question in such short a time. I mean, there are so many examples that one could give. But the point is that the bottom line is the feminist principles of us not stepping in and trying to protect women from structures of power, but empowering them, collectivizing them, strengthening them so that they can engage and negotiate with those power structures.
Thanks, Renu.
I'll just come in here from my angle. I think that what quite a lot has been written about is the tendency by public health programs to see communities as homogenous groups of people with similar interests. And I think a lot is written about how the fact that communities are often very divided. There are huge power differences within communities. People have different interests. Men have different interests to women. Older women have different interests to younger women. People that are more affluent and community leaders have different interests to people maybe who are less successful. So I suppose the thing really around that is that you don't have one peer education program in a community. You go into a community and you reach out in different ways to different groups, and you'll use different methods of organizing and mobilizing, and you'll have to have different people involved. So I suppose what we've said is that communities are multi-layered with national, state, and global levels of analysis, but within communities, there will similarly be power structures and hierarchies, and that programs need to very explicitly plan, you know, I mean, being involved in an AIDS program in South Africa where a huge amount of effort, young people needed condoms, and a huge amount of effort was put to bringing a caravan to the center of the town to make condoms available. And yet there was no way that young people were going to queue round and round the block in a central place where their parents and their mother's friends were coming and their teachers and so on and so forth. So those kind of things have to be taken for granted. And at some level, it seems obvious, but at another level, when you're getting funding for a community program, it's often much more simple to say, well, we're going to go into this community and do this and that, and not to tease out the differences and complexities. And I suppose that's one of the points that we're making in our article, is that public health, understandably, I mean, obviously understandably, but there's always pressure for inputs, outputs, simple solutions, and bottom lines. And in fact, the world doesn't operate like that at all. And I suppose that's the plea that Renu and I are making in this paper, is to take account of this complexity and not to try and simplify.
Cathy, you'll be telling us next the world doesn't operate on log frames, which I suspect is possibly also true. We've got one last question, just to wrap things up, and that's really the question about bringing, if we see this discourse around, if you like, two levels. I'm simplifying the question, but if it's a discourse around two levels, the community level and the policymaker level, how do we ensure that that's a bi-directional flow of information? It's not just bottom up or not just top down. What are the strategies for ensuring engagement between those two levels?
And do you want to?
Yeah. So that is the challenge. Am I speaking or Cathy speaking?
Please,
so
Renu,
from my
ahead.
perspective, that is a huge challenge, because the information from the top does not filter down in ways that people in the communities can understand. This is our frustration with the work that we do, that the government has so many programs for people and for targeted programs for specific groups of people. But there's no information dissemination, adequate information disseminations. And so there are problems with people accessing that. So that continues to be a challenge. And I wish I knew how that could be answered, but I am flummoxed by this challenge myself.
Can I just make a quick comment? For me, from my perch, the issue is not so much around strategies. I think the strategies of people communicating with one another are well understood. It's more around an issue of political will, and whether there's political will from the top to listen to the grassroots, and also whether people in grassroots, as Renu pointed out in her talk, have got the time or the capacity to communicate in ways that maybe are not necessarily familiar to them, to people maybe who speak different languages, etc., etc., etc.
Yeah.
Renu and Cathy, thank you so much. Again, there's actually a whole host of questions that I think we will hopefully be addressing over the course of the next couple of years during the Lancet Commission. But for now, I'm going to wrap things up with an enormous thank you to both of you. Just a quick reminder to everybody watching on YouTube that the next seminar will happen in 2 weeks' time, when we're delighted to welcome Khadija Mawala from Tunisia, who will be talking about human rights and gender, and again focusing on action at community levels. And if you're interested in finding out more about the work of the overall Lancet Commission on Gender and Global Health, please do look at the websites of both the United Nations University International Institute for Global Health based in Kuala Lumpur, and the Centre for Gender and Global Health based at UCL. And hopefully both of those web links should be on the Eventbrite. but otherwise we can certainly pop them into the chat of this YouTube channel. There have been a couple of questions for requesting further information, and we will be putting, we are in the process of pulling together a resources page where we'll be able to compile the resources that have been mentioned in all of the talks that we've had so far. For example, today somebody asked for a link to the SDG gender index. We'll be able to put all of that onto the resource page, which will hopefully be up and running in a very short space of time. But for now, Renu and Cathy, thank you very much again.